All right, we're gonna go through all the competition shoulder special tests right now. So the first test we're gonna do is Speed's test. Speed's test is for a bicep strain or bicep tendinopathy. You're gonna have your patient put their arms straight in front of them with a slight, maybe 20 to 30 degree bend in their elbow, and you are gonna resist as they go and do shoulder flexion. So I'm gonna resist here. Oh, forgot. Gotta make sure you're holding that bicep tendon. So you're gonna make sure you hold that bicep tendon to feel if it's moving in or out of the groove or subluxing. So then you're gonna resist them and they're gonna go all the way up in shoulder flexion and you're feeling the bicep. Bicep tendinopathy, looking for weakness or pain. I got your boy Yergy. We don't like Yergason. So we're gonna go like we're gonna shake Yergason's hand, but we're gonna grab their forearm instead, but we don't like him. So instead, I'm gonna pull this way and she's gonna pull that way. You're doing resisted supination. So I want you to go that way while I go this way. And that is also for bicep tendinopathy. Weakness or pain is what you're looking for. Ludington's, I didn't think you were looting and you now must put your hands on your head. You guessed it, bicep rupture. We are gonna take our fingers, we're gonna go right at that distal bicep and we're gonna go down as she is trying to flex her bicep and go up. And you're looking for weakness, bicep rupture. That's Ludington's. Now we're getting into the labral test. So now we're gonna do the apprehension relocation test. I'm gonna have her flip her around so her feet are on that side, her head's on this side, and she's on her back. We're gonna have our patient scoot all the way to the edge of the table. I am going to grab like right above the arm, or like radius ulna near the hand, and I'm going to be externally rotating her. She's gonna get to the point where she goes, I have apprehension. Then you're gonna go to that relocation part of the test. So when she says she doesn't like this, I'm gonna take my hand and I'm gonna put it right on the humeral head, and then you're gonna see I'll be able to externally rotate more. And then I can take my hand off and she's gonna feel that pain return. So step 1, externally rotate. Step 2, relocate and more external rotation. Step 3, remove and see if the pain comes back again. Thank you, patient. That's an apprehension relocation test. Sometimes we like to call that the crank test. And then the surprise part, the when I took my hand off, is also called the release test. All of that's for a labral injury, a GH injury, or shoulder instability. Next, I have the Fulcrum Test, very similar to that, so I'm gonna have her flip around again. The only difference with the Fulcrum is you're gonna increase the fulcrum. So I'm gonna put my fist right under her, like to the posterior side of her glenohumeral joint, and then you're gonna do the same thing. You're gonna actually rotate. Same thing, you're looking for pain or apprehension, and it's for a labral injury. Perfect, you can stay there for a second. Now in this position, I'm also gonna do the posterior apprehension test. So what I just did was the apprehension, now I'm doing posterior apprehension. So I'm gonna take their arm and I'm gonna go here. Make sure that they're all the way off the table a little bit. And all I'm doing is applying a downward force, and I'm trying to posteriorly feel that humeral head coming out that back side. Apprehension or feeling like it's coming out or feeling loose is going to be a shoulder posterior dislocation or subluxation. Next, I have O'Brien's test, so my patient's going to sit up for me. O'Brien, don't confuse it with Speeds or empty can. They're kind of the same. So what you're going to do is thumbs down straight in front of you, straight there. Then what you are going to do is I'm going to resist her doing shoulder flexion, and she's going to say, ow, I have pain. Then I'm going to supinate her hand, and I'm going to do that again, up. And she's going to say that the pain went away. So weakness or pain is what you're looking for, and you're also looking for it to be more when she's in that pronated thumbs down position. It's a labral tear or a GH capsule injury. Next, I have a labral test. It can also be called many things. Labral test, labral crank, labral clunk, slap, or compression rotation test. So again, this is the labral test, the labral crank, the labral clunk, the slap, or the compression rotation test. You're gonna have that patient lie down on their back. You are going to grab the proximal humerus, and you're gonna be applying like an anterior force. So I'm pulling towards me, and at the same time as I'm pulling towards me, I'm causing, got a little clunk there. We're going back and forth, and we're internally and externally rotating. We are looking for a clunking sensation or some pain, sit up for me, and that's a GH or a labral tear. Again, lots of names: labral test, labral crank, labral clunk, slap, or compression rotation. And you're looking for that clunking sensation. Now we got the jerk test. So jerk test, I'm going to feel up here at like the bicipital groove or glenohumeral. I'm gonna kind of grab the proximal humeral head. And first I'm just gonna see if they have some motion, and I'm gonna move externally and internally rotate their arm. And then if they are good with that, I'm gonna go into the jerk part of it, and they're a jerk, and we're gonna make them hit their face. So I'm going to be palpating right here at the top and stabilizing the shoulder. I'm gonna take their arm and I'm going to jerk it to that side. And so you're going across the body. That's for a posterior inferior labral tear or instability. You're looking for pain with that. So you start here just to make sure that that doesn't bug them. Then you're going across their body and you're doing kind of a quick jerking motion. Next, I have passive compression test. So I'm gonna have them lay down and they're gonna lay on their side for this test. Great. And then I am going to stabilize up here at the superior shoulder. I'm gonna take the arm and I'm going to push up. So I'm using my hand to be on like the trap and clavicle area, and then I'm just pushing up from the elbow in superior fashion. And that I'm looking for pain, and that's also for a slap tear or a labral tear. Next, I have the anterior slide test. So what the anterior slide test is, I'm gonna have them put their hand on their hip. I'm going to stabilize here. I am going to apply a superior force while she resists down. So she's trying to put her elbow towards me. I'm trying to push her elbow up. So push, push, push. I'm looking for pain, popping, clicking, especially in that anterior side. That would be a slap tear for a labral tear. Now I have load and shift, which is for a glenohumeral ligament sprain or a labral tear. It can also be called glenohumeral joint play. So load and shift or glenohumeral joint play. What I like to do is grab like clavicle and spine of scapula. I'm gonna take my hand and I'm gonna grab the humeral head. Once you grab the humeral head, you can have your patient relax, and you should be able to move the humeral head anteriorly and posteriorly and feel it. You're gonna feel a little bit of movement. You're looking for laxity pain or like the humerus to be subluxing, and that is for a GH sprain or a labral tear. Then I have the anterior drawer test. Patient's gonna lay on their back again. I am going to grab their proximal humerus. I'm gonna stabilize clavicle and scapula again, and I'm just going to be pulling the humeral head anteriorly. So grab humerus and try to pull that towards me. Looking for laxity, and that would be the anterior capsule or labral damage. Posterior drawer, same position, but instead of pulling up, you guessed it, we're gonna go posterior. So I'm gonna grab the humeral head. I can have her slide off the edge of the table so I can really get that posterior action going. And I'm gonna go posteriorly with that humeral head. And that's insufficiency of the posterior capsule or labral tear. All right, sit up for me. So those are all the labral tears. Now we're gonna get into the ACSC pathology. Now I'm gonna do the piano key test. So I'm gonna take my index finger and I'm gonna put that on the distal clavicle. My thumb is just gonna go on the spine of the scapula, and I'm gonna try to play the piano with her clavicle. And I'm gonna see if there's any laxity. That would be for an AC sprain. Next, I have the AC compression test. So I'm gonna take my hands, cute little interlaced fingers. I am gonna go on her clavicle and her scapula, and I'm gonna push my palms together. And that is going to be the AC compression test. And that's for AC pain, which would indicate an injury to the AC joint. And then I also have the AC stability or joint play. And so what I'm gonna do is I'm gonna take two fingers. My other hand's gonna stabilize scapula. And then I'm just pushing down on that distal end of the clavicle, and I'm looking for laxity, and that would be an AC sprain. Then I have the SC stability test or joint play. So I'm going to go on the medial side now, and I'm going to do the same thing on that medial side, SC sprain and laxity. Then I have the sulcus sign, which could be either AC injury or it could be GH injury, depending on where the gapping is. So I'm going to be looking right here. So I'm going to stabilize the superior shoulder. I am going to grab the humeral shaft, and I'm going to pull down that arm. And I'm looking, if there's gapping at the AC joint, AC sprain. If there's gapping at the GH joint, that would be more of a GH injury or labral tear. Empty can test now. We're gonna have our patient thumbs down the front. Looks kind of like O'Brien's, but it's not. So thumbs down in the front, but instead I'm gonna move them to 45 degrees out. I'm gonna take 2 fingers and I'm gonna resist them doing flexion again. You're looking for pain and weakness, and that's a rotator cuff strain. Drop arm test, what I'm gonna do is I'm gonna take my patient's arm and I'm gonna put them into full abduction. Now I'm gonna say, when I let go of your arm, please slowly release it to your side, and I'm gonna follow their arm to make sure if it does drop, I'm there to catch it and they're not in too much pain. She was able to get it fully down, so she's not injured. If she did have an injury, it would slap down to her side, and that would be a rotator cuff tear or supraspinatus injury. Also the empty can was for rotator cuff. You're looking for weakness. Next, I have the rent test, which is also called the trans-deltoid palpation test. So I am going to go on the deltoid, and I am going to use 2 fingers, and I'm just going to be feeling the anterior and posterior side of the joint capsule. And I'm going to take her elbow, and I'm going to internally and externally rotate it. What I'm looking for is a depression of like 1 finger in that posterior side, and that would be an indication there's a rotator cuff tear. Gerber lift-off test, I can have my patient turn around and stand up. They're gonna be turned around, their arm's gonna be behind their back with their elbow at 90 degrees of flexion. First, I'm gonna say, can you please lift your hand off your back? Love it. They can do that. Once they can do that, then I'm gonna say, okay, go back to that first position, and I'm gonna resist their hand and let them resist back. Inability to do that motion or weakness would indicate a subscapularis tear. Then, all right, I'm gonna get into my thoracic outlet syndrome tests. So first I'm gonna do with Adson's, and Adson's, we're adding our hand to our arm. So I'm gonna find her distal pulse using 2 fingers, not my thumb, and wanna be more on the radial side. Once you find her pulse, you're gonna put her a little bit into shoulder extension, and you're gonna have the patient now look towards her hand. What I'm doing is I'm looking for a diminished pulse, numbness, tingling, or color change. And I'm gonna compare this to the contralateral side. Just like all of these tests, I'm gonna compare to the other side, but I can take the pulse on both sides, and I can also take her pulse before and then after she adds her hand. Decreased pulse, numbness, tingling, color change would indicate a thoracic outlet syndrome or TOS. Now, Allen, we don't like Allen. So what I'm gonna do, there are 2 ways to do this test. One is very similar to Adson, a little bit of extension, finding the pulse, but instead of looking towards, you are looking away. So that's the first one. The second part of this test is Allen's a loser, so we gotta make an L with our arm. We are gonna feel the distal pulse again, and she's gonna look away. So first you do a little bit extension, arm down, and now you're gonna put her into this horizontal external rotation and look away. You're looking for that same diminished pulse, color change, numbness, weakness, TOS. And then I have military brace test, so I can have my patient stand up. I'm gonna take their pulse on both sides. I'm gonna put them into slight extension, and then I'm gonna have them at attention like they're in the military, and they're gonna put their head to the ceiling. And that is going to be the military brace test. You're looking for diminished pulse, color change, numbness, tingling, weakness, and that's all TOS. Next I have ruse test. I'm gonna have my patient sit down. They're gonna put their hands up here in this position, and they're gonna open and close their hand for 3 minutes. I'm looking for numbness, tingling, color change, diminished, not pulse, just numbness, decreased strength, inability to be able to do that, and that would also be for TOS. Next, I just have a test to check range of motion. So I'm gonna do Apley scratch test. I'm gonna say, patient, can you please actually touch your shoulder? Great, can you go behind your back and touch your shoulder? Love it, and now can you go behind your back with your arm under like you're fastening your bra? Great job. You would be able to touch all 3 spots, and that is you're looking for the inability to touch or pain for a structural problem, impingement, anything like that. All right, now I have Spurling's test. So Spurling's test is looking for radiculopathy, which is a fancy word for numbness, tingling, any kind of pain that's radiating, and it's a nerve root impingement. So for Spurling's test with a P, what you are going to do is you're going to have your patient put their head to their side, and you are going to apply a downward force. So I'm pushing down, and this would be the side that she was having problems with. And then once I've done that to the side and that's okay, Then I'm gonna have her a little bit into extension onto this side. So that's Spurling. I'm looking for pain. I'm also looking for any kind of radiating pain for radiculopathy or nerve root impingement. That was Spurling's. Now I'm gonna do Sterling's. Sterling's is the exact same test, but I'm on the opposite side of the pain. So instead of her pain being on that side and going towards that way, I'm gonna go towards the opposite side of the pain, and then I'm gonna go posteriorly, and you're looking for that same radiculopathy. And then I have Bakody's, or shoulder abduction sign, which is basically the same thing we just did with Spurling and Sterling, but they're actively doing it themselves. So you have your patient put their arm on top of their head, and then you can have them put their head towards their arm. So first, head straight, second, head side. Same thing, you're looking for radiculopathy for nerve root impingement, and that's Bakody's sign or shoulder abduction sign. Now I'm gonna go to the impingement tests. So impingement affects the long head of the bicep, the supraspinatus, or the subacromial bursa. What I'm gonna do is I'm gonna go Neer's test, which is you're gonna think near their ear. I'm gonna take their arm, I'm gonna go all the way in full abduction, and I'm gonna compress that head and that arm together. I'm looking for pain, and that's impingement. And then Hawkins-Kennedy, we're gonna put their hawk in the sky, and you're going to internally rotate and then adduct and internally rotate them. You're looking for pain, and that's also for impingement. And then lastly, we just have a general circulatory assessment. So anytime someone has any injury, you want to check like their circulatory system and make sure that they are still giving nerves, blood vessels, everything getting everywhere. So I want to make sure that I would check my distal pulses. And I can make sure that the brachial pulse and the radial pulse are the same and they're bilaterally the same. I can also do dermatomes, which is skin sensation. I can have them close their eyes. Can you feel this on both sides? Does it feel the same? I can do point interaction, so how many places am I touching? And then also we have myotomes, so it's checking the muscular strength of different body parts. That's a different video. So these are the main special tests, and then you also need to be aware of dermatomes, myotomes, cranial nerves. Thanks.